screens?
Initially, I'll change it, sir.
Okay, I'll tell
Then
you.
we'll see.
Okay. I'll just say next slide, next slide. Okay.
Yes, yes.
Nishan, start.
Yes, sir. Redima.
Sir, are
very-
we audible?
A very good evening to everyone and welcome to ISA online PG class. Today we have a very important topic and I think no anesthesiologist can escape from this. That is pregnant patients with cardiac morbidity for emergency LSCS and or any operative intervention and its anesthesia management. Emergency LSCS may prove challenges sometimes to the attending anesthesiologist if the patient has some comorbidity diseases. That challenges get enhanced manyfold, and if she has an underlying cardiac pathology, it can become nightmare for the anesthesiologist, be it in the institute and the periphery. Today's class dwell upon the various challenges in such patients and their meticulous manifestation. As a custom or a tradition, we will first invoke the blessing of Ma Saraswati before we proceed further.
Saraswati Namastubhyam Varade Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada.
Now I request our Honorary Secretary Dr. Vajwa sir to kindly throw some light on this very important topic and further start the class for us.
Thank you, Redima. I request Dvetya sir to at least start the proceeding. The President sir is here. Dvetya sir, unmute yourself. Yes, sir.
Yeah, good evening. So welcome to this ISA PG class. This is a very important education initiative started by the ISA. And I welcome Dr. Suresh Nair and his team to conduct this session. This is a very important topic that has been pointed out. And I don't think I will take much time between you and the class. So welcome, and I wish you all the best. And I hope all of you will benefit from this endeavor. And please spread the word amongst your friends and colleagues so that more and more PG students and other practitioners can benefit from these classes. Thank you. Over to you, Dr. Bajwa.
Thank you, sir. Thank you very much. Actually, the topic is such, the cardiac patients, everybody encounters them even when you start the first year postgraduate career. You may get a case of emergency section with the cardiac pathology and sometimes the booked cases or sometimes the unbooked cases. The worst thing is when the unbooked cases come with some complications and comorbidities, especially the cardiac. It's very difficult during the PG curriculum and it's become more challenging when you encounter such cases in the peripheries during the emergency surgeries at night, where you can't even refer these patients, don't have time also. That is a biggest nightmare for any attending anesthesiologist. You are in dilemma whether to save life of a patient or the children of the fetus or whatever. It's a very difficult situation. We have seen those situations many times. And none better than Dr. Suresh Nair and team to present this case because there will be many doubts in the minds of people, the PG students and the practitioners as well as other academicians who will be attending this session. So you can freely ask your question. You can type your question in the chat box during the presentation, so that at the end you can also, your question will be answered by the team. Thank you very much, sir, for joining this class, and I hand over the stage back to Dr. Ridhima and her team.
Today, I have another coordinator, Dr. Badisha Chaudhary. I welcome you, Badisha. And she's in Town Hospital, Guwahati. I request her to kindly read the CV of the moderator and introduce them.
A warm good evening to everyone present here. Today we have amongst us Professor Suresh G. Nair. He is a senior consultant and head of the department in anesthesia, pain medicine and critical care, Aster Medicity, Cochin, India. Sir is an international speaker. He has graduated from Trivandrum Medical College and postgraduate from MS University in Baroda. He has got an experience of 25 years. He has been the organizing chairman for the 17th National Conference of the Indian Association of Cardiovascular and Thoracic Anesthesiologists. Sir has been an examiner for MD in anesthesia, DM in cardiac anesthesia, and fellowships in anesthesia and critical care. He has been actively involved with postgraduate training in anesthesia, including cardiac anesthesia and critical care. Sir has got honorary fellowships in transesophageal echocardiography and in cardiac anesthesia. Sir has been awarded the Lifetime Achievement Award by the Cochin Heart Foundation. His areas of interest are mainly pediatric cardiac anesthesia and intensive care. Secondly, we have
Badisha, turn off your mobile. I think you have chosen two devices. One is echoing. You should turn off one device. The mobile, I think you should turn off.
Is it fine now, sir?
Yeah. No,
Okay.
it's still echoing. Anyway, you carry on. Then I think after you get mute, then turn
Yes,
it
sir.
off.
Next, we have amongst us Dr. Jyotil Lakshmi Nair, consultant at Aster Medicity, Kochi. Ma'am has a qualification of MBBS DA followed by DNB with 19 years of experience. She has been managing gynec obstetrics, surgical oncology, and general surgery at Aster. She is active in managing critical care patients post-operative and preoperative, and her areas of interest are high-risk obstetrics and labor anesthesia.
Thank you, Badisha. And I welcome our moderator. And before we proceed further, just a small announcement that please kindly keep your video and audio off during the session. And if your video is on, kindly be dressed properly. And you can type all the questions or queries in the chat box, and all will be addressed at the end of the session. So now I request our moderators to kindly introduce the present and take the session further.
Thank you, Ridhima. And can I start?
Yes,
Yes,
sir.
sir.
Please start.
Yes,
Sir.
sir.
Okay. Thank you very much. And I hope Dr. Jyoti and Dr. Nishana are ready. Nishana is my postgraduate. She's a third-year postgraduate in the department. And her full name is Nishana Sherin. Thank you for giving me, Dr. Bajwa and others, for giving me this opportunity, or our institute for being part of this PG training program. Tetralogy of Fallot is something that all of us have heard of and seen, but when it comes to pregnancy and delivery, it becomes a very difficult task, not only in a small, not only in a small hospital, but even in a big hospital, it becomes a major issue that we have to tackle. The incidence of Tetralogy of Fallot is about 3 to 5 per 10,000 live births, with an overall incidence of 5 to 7% of all children with congenital heart disease. Now, we all know about the famous story of Blalock, Taussig, who did the first shunt for these patients in 1944. And thus, we could save some of these children. In 1954, what really happened was that the first surgical repair was done, because the BT shunt is generally considered as a palliative procedure that is actually done. So the first surgical repair for tetralogy was done in 1954. Since then, things have changed because earlier days, even when I was a student who was just starting cardiac anesthesia, we used to see many of these children who are 4 or 5 years old who come up for surgery. But today, the entire scenario has changed, and the dictum is to get them as early as possible into the operating room, and which operate on children as small as 3 months of age onwards to do a corrective surgery. Now, many of these children whom we have operated in the past have actually grown up, and although uncorrected tetralogy of Fallot, the survival rate is less than 10 or 15% in the third decade. Those children who have undergone a surgical repair, many of them have grown up into young women, and as you can expect, any normal human being, many of these ladies would like to have children. So in future, we are going to see more and more of these children who had corrected tetralogy of Fallot coming up for with pregnancy. We have to give them proper advice on as well as what the plan for the delivery as well as cesarean section. Although corrective surgery has been done over the years, it is important to remember that it is not a full correction. Many of these children who have actually grown up into the second and third decade of life can have morbidity like RV dysfunction, which we'll discuss in the next few slides. So even a corrected tetralogy who comes up for surgery will have their own problems which we have to tackle. Now, what we'll do in this session is that we look at the entire subgroup of patients, which we'll see in different types, who actually come up from the midterm, that is 6 months of age towards the delivery side. When they come up for surgery, what is the best method of giving delivery to these patients? What happens during an emergency when you get these these ladies into the operating room? All this will be discussed in the next few minutes. Dr. Ishma, can I have the slides on, please?
Are you want to share or shall I share, sir?
Please share. Somebody can share it with me. So
Okay. Okay.
you can go to the next slide. Next one. Okay, Dr. Jyoti, can you introduce the case that we are going to present today?
Dr. Jyoti, unmute yourself. Unmute, please.
Good evening, respected faculty. We are going to start off this session with a case scenario, followed by a few questions to Nishana, which she will answer pertinent to that question. The case scenario is a 23-year-old lady who presents.
Can you go to the next slide? Yeah. Okay.
She is a 23-year-old lady, presents at 28 weeks of gestation with with symptoms of breathlessness that has aggravated since the last 2 weeks. The patient is finding it difficult to lying down and spends most nights sleeping in a head-up position. She is a known case of Tetralogy of Fallot in childhood who has undergone a corrective repair at the age of 1 year. So, and the surgical details reveal that a transannular patch was done to repair the right ventricular outflow tract obstruction, and a ventricular septal defect was also repaired. She was on a regular follow-up till the age of 5, during which she was informed that there are no residual lesions. Since then, she has not been on a regular follow-up. She got married about 2 years back, and there's no history of any abortions in the past.
Next slide.
She is a thin-built, normally nourished female. There is no cyanosis, clubbing of fingers, icterus, or pallor. Her BP is 120/80, and her heart rate is 100 per minute. Her routine biochemistry lab parameters were normal. The ECG showed a P pulmonale and a right ventricular hypertrophy. RBBB was also present. The echo findings showed a normal LV function and the RV was grossly dilated. There was a moderate to severe pulmonary regurgitation and mild to moderate tricuspid regurgitation with a PA systolic pressure around 30 millimeter of mercury. This is a case scenario, and pertinent to this case scenario, we are going to ask Nishana a few questions regarding Tetralogy of Fallot, the new normal physiological implications of pregnancy related to TOF, and a few questions regarding corrected as well as uncorrected TOF presenting with pregnancy. So the first question.
Nisha, you'll have to tell to change the slides, huh? You'll have to tell them to change the slides.
Okay. The next slide. What is Tetralogy of Fallot?
Tetralogy of Fallot, as its name suggests, is a tetrad of 4 anatomical malformations. That is a ventricular septal defect, a right ventricular outflow tract obstruction, right ventricular hypertrophy, and overriding aorta. It results due to malalignment of infundibular septum anteriorly.
The next slide, please. What are the survival chances in an uncorrected Tetralogy of Fallot to adulthood?
Uncorrected Tetralogy of Fallot, the child will 30-year survival rate of child with uncorrected Tetralogy of Fallot is about 10%, but with corrected Tetralogy of Fallot, the 30-year survival rate rises up to 85%.
The next slide, please. What do you mean by Tetralogy of Fallot with pulmonary atresia?
Tetralogy of Fallot with pulmonary atresia is a rare a spectrum of disorder with complete absence of pulmonary arteries. There is no antegrade pulmonary circulation. Here the pulmonary circulation is maintained by either a patent ductus arteriosus, which is known as duct-dependent circulation, or either another form is formation of major aorta pulmonary collaterals between the aorta and pulmonary circulation.
So what are the drawbacks of Nishana of pulmonary atresia? Because many of these children with pulmonary atresia will actually look pink in color. The problem is that can you tell me what are the actual problem when you have pulmonary atresia with MAPCAS or PDA dependent circulation?
Have pulmonary congestion, increased blood flow, because there is a systemic circulation going into the pulmonary circulation. There will be increased pressures, pulmonary artery hypertension, and pulmonary hyperemia.
Hyperemia, what happens over a period of time?
Over a period of time, they can go into ventricular failure, ventricular hypertrophy, ventricular dilatation, and ventricular failure.
LV, ventricular dilatation and failure. But more importantly, what will happen is that the lungs are exposed to the systemic pressures because these collaterals actually come from the aorta, isn't it? So you'll rapidly develop pulmonary arterial hypertension, and that will cause further worsening of the RV failure. Okay.
The next slide, please. What are the palliative procedures done for Tetralogy of Fallot? And is this a common procedure done these days?
There are different palliative procedures done for Tetralogy of Fallot that is mainly classified as either it can be alleviation of the right ventricular outflow tract obstruction with a balloon stent or dilatation of the infundibular muscles, or it can be a palliative shunt between the systemic and pulmonary circulation. There are several named operations like modified Blalock shunt, that is Blalock shunt, that is a Gore-Tex tube between the pulmonary artery and ipsilateral subclavian. Then the original Blalock shunt is between the subclavian artery and the ipsilateral pulmonary artery. Then there is water stunt shunt, which is between the ascending aorta and pulmonary artery. Then there is Port's procedure, where there is a shunt between the descending aorta and pulmonary artery. And there is Glenn's procedure, where there is a connection made between superior vena cava and pulmonary artery.
What are the problems with each of these shunts? For example, if you take BT shunt, you do it when your child is very small, like 6 months or something. What happens after that?
There is especially for this blalotoxic shunt, directly the subclavian artery is made to anastomose with the pulmonary artery. This causes the kinking of the vessels, and later the child can present with the pulmonary hyperemia, then pulmonary hypertension, and resultant left side.
Not exactly, because what happens when you initially put a BT shunt, initially there may be a little overflowing of blood, but when the child grows up, now the shunt is an artificial structure that you have kept there, especially the modified BT shunt.
Child grows out, it may not be adequate for the child.
Yes. So the child will become intensely cyanotic over a period of time, isn't it? What about pot shunt and water shunt? We don't see it nowadays, but what are the drawbacks of these shunts?
There are also connections. There is compromise of the supply of blood to the side where the shunt is created, the limbs.
Okay. Is it a common procedure, all these shunts and all that you see nowadays?
Nowadays, we prefer to do corrective procedure. These are done in children with extreme prematurity and who are not fit for the surgery, or in emergencies where the cyanosis and the hypoxemia to be corrected. And after this shunt, we wait for the child to grow up and we will go for a corrective surgery.
So water shunt and the pot shunt are generally not seen nowadays. The other, like I said, BT shunts are also done very rarely, except in those situations where there's some other problem which prevents a corrective surgery being done in these patients. Okay. Next slide, Jyoti, go ahead.
What is the corrective surgery done for Tetralogy of Fallot?
The aim of corrective surgery is to alleviate the right ventricular outflow tract obstruction by dilating it with resection of the infundibular muscles, then separating the two ventricles with a patch. Ventricular septal defect is corrected with a patch, and the overriding aorta is septated back to the left ventricle.
So you close the VSD and then open out the right ventricular outflow tract. Okay.
And in case if the right ventricular outflow tract is not dilation of that right ventricular outflow tract is not adequate, we may use an annular patch.
Transannular patch. Okay.
Next, describe the physiological changes that you see during normal pregnancy in context with the Tetralogy of Fallot.
Physiological changes
No,
pertinent.
first, Jyoti, let us first see what are the normal physiological changes that you want to tell about during pregnancy. Then we'll go to the pathophysiology of physio.
Then there are several physiological changes that can be seen in the mother to adapt to the requirement of the fetoplacental unit as well as the mother during the pregnancy. There are innumerous, which are more important, are the increase of plasma volume up to about 40 to 50%, and an increase in erythrocyte volume of 20 to 30%, which is very less compared to the increase in plasma volume, which results in physiological anemia. There is an increase in stroke volume of about 25 to 30%, and an increase in heart rate about 15 to 25%, and a resultant cardiac output increase of 40 to 50%. There is a decrease in systemic vascular resistance, which is about 20%. This is very important. Which is very important in the uncorrected tetralogy of Fallot, because this can alter the increase the shunt. Then there is decrease in peripheral pulmonary vascular resistance about 35%. Then there is increase in annular diameter of all the valves except aortic valve. And considering the respiratory system, there is increased minute volume to 40 to 45% because of increase in tidal volume and as well as respiratory rate. And there is resultant increase in work of breathing, and a decrease of FRC about 20% due to cephalad push of the diaphragm due to growing uterus. Then there is increase in procoagulant factors 1, 7, 8, 9, 10, and 12, and decrease in factors of 12 and 13 protein as antithrombin 3, which makes the pregnancy a very procoagulant state. Then there is aortocaval compression due to growing uterus in the late second and third trimester.
Next slide, please.
It would.
How do the physiological changes that normally affect pregnancy impact a patient with an uncorrected and a corrected tetralogy of Fallot?
As
You go to the next slide. Yeah.
We will discuss it as separately as uncorrected and corrected tetralogy of Fallot. In uncorrected tetralogy of Fallot, there is in pregnancy there is increase in plasma volume, which results in increased preload, along with the decrease in systemic vascular resistance that increases the rightly left shunt, and this worsens the hypoxemia and cyanosis. Increased preload also precipitates the right ventricular hypertrophy, right ventricular dilatation, and right ventricular failure. Increase in plasma volume is not balanced with the erythropoiesis, which results in the physiological anemia. Then there is poor tissue perfusion and worsening of tissue oxygenation. This can affect the placenta blood flow. So these patients are more prone to premature labor, and the children are more prone to become small for gestation age babies, intrauterine growth retardation, etc. Then there can be iron deficiency anemia in these patients. Pregnancy is a prothrombotic state. Along with that, due to increased hematocrit value and thrombocytopenia of pregnancy, it is also there is also increased risk of bleeding. So risk of bleeding has to be balanced with the while we are giving any intervention, we have to be careful and balance. There should be a balance between considering the prothrombotic as well as bleeding state of the patient. Then, as we have mentioned, the minute volume also increases significantly. That increases the work of breathing, that increases the oxygen demand. And during the labor, there can be increased blood flow back to the mother from the placenta due to autotransfusion. That is also causing increased load on the ventricles, and blood loss during the pregnancy, labor or cesarean section can also affect significantly due to hypovolemia and reduced tissue oxygen delivery. In
Go ahead. Go ahead.
In corrected of the main consideration is regarding the lesion, type of lesion that is present in the patient. If the patient has both pulmonary regurgitation and pulmonary stenosis, a better outcome is expected, because the pulmonary stenosis is actually protective for the right ventricle from the volume overload resulting from the regurgitation. In cases of with the isolated pulmonary regurgitation, there is increased RV volume overload from the regurgitation when compared to this pulmonary stenosis. So worse outcome is compared to the other group.
Yeah, this is very important, because today we are going to, because of the excellent programs that we have in various states, most of the children who have tetralogy of Fallot undergo surgery in early life. So what we are going to see in the next few years is corrected tetralogy coming for pregnancy and delivery. And one of the important things these people have is that whether there is some element of pulmonary stenosis along with the pulmonary regurgitation, because when you have pulmonary stenosis, it produces some degree of ventricular hypertrophy. And this ventricular hypertrophy will prevent too much of dilatation of the right ventricle. So if in fact, studies have actually shown when we do a pulmonary valve replacement, those patients had a previous PR plus PS have fare better than those patients who had only pulmonary regurgitation, because their ventricle regresses much lesser than that of a patient who had PS with PR. So this is a very important point that we have to remember when we evaluate the pathophysiology of these children. Next slide, please.
What are the different categories of pregnant patients with tetralogy of Fallot that are likely to come across during pregnancy and for delivery?
I think, Nishant, this is a very, very important slide that you're going to present. Next slide, please. And you have to go in detail about this.
So there are, according to their presentation, they can be classified into 4 groups. Group A is a corrected tetralogy of Fallot, and the patient has no significant residual or recurrent lesions and she has a normal right ventricular function. These patients, then we have second group, group B. There is a residual mild to moderate pulmonary stenosis, moderate to severe pulmonary regurgitation, and the patient may or may not have right ventricular dilatation, but the right ventricular function is normal. In group C, there can be moderate to severe pulmonary valve dysfunction, that is either stenosis or regurgitation, but right ventricular function is impaired. In group D, the patients are either unrepaired, palliated, or the patient is cyanotic.
So as you go from category A to category D, what does it mean?
The risk of postoperative risk of complications during the antenatal, postnatal, and labor is increasing as we go from A to D.
Okay, and the other thing I want to know is what is the difference between group B and both have got pulmonary regurgitation? What is the actual difference between group B and group C?
That is functioning of the ventricle, right ventricle function is intact for group B, but there is pulmonary dysfunction as well as significant valvular lesion in valvular dysfunction.
I think all the postgraduates should understand that the major difference between group B and group C is that the RV function. The RV function is significantly impaired in group C, whereas the RV function is mild or normal when you have group B, and that makes a lot of difference in the outcome of these patients, isn't it? Okay. Shall we go ahead?
Yes, sir.
Jyoti, you can give your comments, sir, please.
Yes, sir. The next slide, please. Describe the risk stratification tools, if any, for obstetric patients presenting with congenital heart disease.
Next slide.
On various studies conducted by several groups, we have come with several risk stratification models. One of them is modified WHO classification, then there is CARPREG 2 classification, and then there is Zahara group of classification. Here also we can see that the classification is categorized into A, B, C, D, and the difference is that there are two C's present in this risk stratification. And considering each group, we can see that the group A, their prognosis is very good in pregnancy. They undergo the pregnancy like the normal people without any congenital heart disease. When we consider the group B patients, they will have normal ventricular function. So they'll undergo the pregnancy with only mild risk of arrhythmias, hemorrhage, or any significant right ventricular dilatation or any right ventricular failure. That is only mild risk. Considering group C, they are considered as high risk pregnancies. They can have increased risk of arrhythmias. They can have increased risk of hemorrhage. They have increased risk of right ventricular failure. They may be asymptomatic and they may have a very good right ventricular function when they are not pregnant, but then when they go into pregnancy and undergo when the physiological changes of pregnancy comes, they'll go into failure. Then considering group D, they are very high risk patients. They are cyanotic. They have and they have already having history of cardiac events, arrhythmias, etc. If they are if they come to the medical care before they are getting pregnant, they should be advised the correction or palliation before coming to the procedure.
So basically what we are looking at is group C. Group C is a group of patients where there's a dilated RV already. And what happens to these patients is that during pregnancy, their RV can become volume overloaded, significantly dilated, and they can go in for RV failure. These are the group of patients where we have to consider whether midway through the pregnancy you need a pulmonary valve replacement or not. Definitely, group D is the worst. As you can see, almost 50% mortality, maternal risk is increased, and it involves both more risk to both the mother as well as the fetus. So group C and group D are the ones that we have to really be careful about.
And so these risk stratification models actually predict the worst outcomes in pregnancies.
Yes.
They are predictors of the outcome. And if given a chance, if the patient presents earlier with a very severe pulmonary regurgitation or RV dysfunction, we can think of correcting the pulmonary. We can give a trial of rather opt for a surgery prior the pregnancy is full blown. We can do that.
Yes. Yes.
Next slide, please. If a patient with unrepaired Tetralogy of Fallot comes at 6 months of pregnancy and an anesthesia team is contacted about this patient, what are your plans for the management?
When the patient comes at 6 months, it is a very good time to assess the patient and understand the category to which we have categorize the patient into the groups we have discussed, and consider risk stratification and tailor a good anesthetic as well as management plan for this patient. The actions, the plan should be considered with discussing with multidisciplinary team meeting, and the baseline cardiac status of the patient to be known by asking her about any features of right ventricular failure or cyanosis or hypoxia, and she can be given a cardiology consultation once in every trimester, where her ECG will be taken. We can look for any arrhythmias. If there are any arrhythmias, we can start her on a beta blocker. If there is severe arrhythmias, we can also consider direct current cardioversion, and if we can take a baseline echo, and with the echo, we can understand the biventricular function, if there is RV dilatation, RV or ILV systolic or diastolic dysfunctions, and the extent of pulmonary regurgitation, pulmonary stenosis, and condition of other valves as well. And we can also go for cardiac MRI if the patient is having a very significant pulmonary stenosis or pulmonary regurgitation, severe RV dysfunction. We can take a cardiac MRI to look for assess the correct, adequate, accurate volume and status of the ventricles. Then we can the patient should be under continuous monitoring for the maternal as well as fetal well-being. A cardiac echo of the fetus is recommended at the age of 6 months of gestation, and we can from the late third trimester, from the beginning of third trimester, we can look for we can monitor the growth scans of the child, the fetus, because the IUGR is very common in the patients with TOF, corrected TOF, and NSTs can be done. And if the patient is we think or we feel that the patient is in prothrombotic state, there is increased chance of thrombus, we can start her on the standard start her on low molecular weight heparin, or aspirin or heparin also can be considered in prophylactic doses. And if the patient presents with a severe RV failure, we can start her on diuretics. She can be suggested with an hospital admission and bed rest. If we are considering bed rest, we have to also start her on thromboprophylaxis. And we will have to tailor a proper anesthesia and analgesic plan for the patient in case of a patient is going for a normal delivery, emergency cesarean section, or in various scenarios we have to prepare.
I think we'll discuss that in subsequent slides. No, I just want to ask you an offline question. Is there any association between mother having a congenital heart disease and the child being born with congenital heart disease?
When we are considering Tetralogy of Fallot, there is chance of 3 to 4% for the child to be having Tetralogy of Fallot if the mother have Tetralogy of Fallot.
One more thing I want to bring up here is that, we do use diuretics if the patient is having congestive failure. But always remember that diuretic can be a double-edged sword. Because if you give too much of diuretics, the patient thrombotic complications can increase. So we have to be very careful about how much fluid they take, as well as thrombotic. You have to balance the two. Okay.
If we're diuretic and taking her as an inpatient, we can monitor her intake output. Intake output monitoring can be done.
The other point I would like to bring up is about prophylaxis against thrombotic complications. We have textbooks actually say ecospirin, but the actual drug that should be used to prevent thrombosis is actually anticoagulants. I don't know how much of ecospirin can be helpful, but even the textbooks actually mention ecospirin to be given to these patients. What about warfarin? Warfarin can we give in these patients?
No, just not
It is
recommended.
only recommended in the second trimester because the first and last trimester will have teratogenic
Yes.
effect.
Because that be something called the warfarin embryopathy. So first trimester you have to be very careful. You should not give it. You can give it during the second trimester, and the third trimester you go back to low molecular weight heparin again. Good. Next slide.
Even before
Yeah.
delivery, do a serial pro BNP also to
Yes.
assess the myocardial functioning, and in cases of when you see a lot of cyanosis also, serial pro BNP is also recommended according to the textbooks.
We can assess the progress of the RV failure if it is there.
The next question is infective endocarditis prophylaxis required in this patient?
Routine infective endocarditis prophylaxis is not recommended for normal vaginal deliveries, but in those Tetralogy of Fallot patients with history of infective endocarditis, or of the patients who are palliated, uncorrected, or the patients who has undergone a VSD correction with a patch within the last 6 months, or the patient have a residual lesion close to the any regurgitation, those patients will require an infective endocarditis prophylaxis.
In the prior slide, we actually forgot to ask Nishana about the regional techniques, regional analgesia and anesthesia. What is the opinion regarding regional analgesia and anesthesia if required? The advantages and the disadvantages.
There is no doubt that the patient requires analgesia, because the adequate proper analgesia can decrease the pain of the patient, thereby decrease the catecholamine release and subsequent tachycardia and other complications arising due to that. So analgesia is needed, but the method of providing analgesia should be very should be very careful. The preferred is epidural analgesia, that too very titrated doses and incremental doses of epidural analgesia is recommended. Spinal anesthesia is not considered as a good option because it can cause very rapid decrease in systemic vascular resistance.
That's basically for uncorrected tetralogy, isn't it?
Yes, I'm talking about uncorrect.
Hmm.
That can cause systemic vascular resistance and decreases the pulmonary circulation, and then further worsening the hypoxia that can cause all the symptoms we have mentioned. And it is also very bad. It can also cause bad outcome for the fetus. And general anesthesia, if we consider all the induction agents are arrhythmogenics, and they can also cause myocardial
I think
depression.
we'll come to that in a subsequent slide, Jyoti.
Even a combination of spinal with epidural is also considered in patients of Tetralogy of Fallot.
I think we'll be discussing this in more detail in the subsequent slides.
Yeah. So the next slide. If the same patient approaches you at term with pain, what is the plan for delivery?
So if the patient comes with pain, first of all, as I have already mentioned, we'll see what is the class of risk stratification it belongs to. If the patient has no coagulopathy, if the patient is not in severe ventricular failure or severe in that condition, we can go for normal vaginal delivery trial with adequate epidural analgesia. It is recommended to go for normal vaginal delivery with epidural analgesia in all those cases where there are no contraindications.
No, let me ask you, put it this way: you have A, B, C, and D category. So, would you use it in all the categories, or you're going to restrict yourself to A, B, or you are going to include all four?
I would go for this plan if the patient is belonging to A, B, or C categories.
D?
D category, depending upon the situation and the presentation of the patient,
Suppose she lands up in fetal distress with a severe
obs-
bad RV or RV dysfunction, general anesthesia is a choice, sir.
Yeah, if it's an emergency for actually you put it this way, if the indication for a cesarean section is only obstetric reasons or some other reasons. So even in category D, if the patient is actually stable, we should consider giving epidural analgesia and try to deliver the patient vaginally. Yes, correct.
The next slide, please. If general anesthesia is planned, how would you proceed? And what are the monitoring modalities will be used for these patients?
If the patient comes with if the patient comes with for an emergency cesarean section and there are contraindications for epidural analgesia, we'll be going for general anesthesia. First of all, as routine, we'll do the pre-anesthesia checkup and confirm her history. Then look for her nil per oral status and we'll verify the informed written consent, and she'll be shifted to the operation theater where all the equipments and drugs required for anesthesia as well as emergency will be made ready, and plus special attention to be given to difficult airway cart preparation, including video laryngoscopes, supraglottic air devices, then anterior airway.
Yeah, general measures for the cesarean section. Yes.
All the IV lines should be connected within air filters because air embolism is a dreaded complication in these patients with ventricular septal defect. And if the patient is planned for general anesthesia, we'll be going for a general anesthesia with endotracheal intubation and invasive lines including arterial blood pressure and central venous cannulation. With arterial blood pressure monitoring, we can know the pulse variation of the blood pressure. Then it can be also used for assessing the ventilation status and adjusting the ventilation accordingly. And a central venous catheter can be used for delivering emergency drugs, and it can also be used if the patient is having severe RV dysfunction. If the patient is in failure, we can look for the cardiac output monitoring through the central venous catheterization. So after securing an arterial line and after attaching all the standard monitors, securing all the lines, we'll go for induction of the patient. The preferred drugs are an opioid, fentanyl, thiopentone, and a combination with the ketamine.
How much would you use fentanyl?
Fentanyl 1 to 2 mcg per kg, thiopentone 4 to 5 mg per kg, and ketamine 1 to 2 mg per kg. Then
Okay, 1 to 2 might cross the placental barrier and cause fetal this thing. So you have to make sure that the neonatologist is available, and then they should be warned that if you're going to give so much of fentanyl. I'm not disagreeing with you, but you have to be careful. You have to have the whole team ready for the baby. Okay.
Then the thing I forgot to mention is about we'll be going for a rapid sequence induction, required pressure and assistance ready. And the paralyzing agent of choice is rocuronium 1 to 1.2 mg per kg. We'll be intubating her with a smaller size tube, 6.5 mm cuffed endotracheal tube, and positive pressure ventilation will be applied, and we will see the arterial blood gas monitoring and alter the ventilation parameters so that there is no hypercapnia. To avoid mainly to avoid increase in pulmonary vascular resistance.
How do you manage the fluid status of these patients?
This
Sir, euvolemia should be always considered in these patients. So even before you start off any anesthetic procedures, a little bit of preloading will be rather helpful to these patients. So preloading with crystalloids of 250 to 500 ml and then you give anesthesia will be very helpful because the volume status has to be maintained.
It's not only that, see these many of these patients for all the postgraduates, they may come with a hemoglobin of say 18 grams. And
Yeah.
then during delivery, blood loss, cesarean section, you may come down to 15, which you think is normal. But what is important to understand is that 18 grams is important for a tetralogy, uncorrected tetralogy, to maintain the tissue oxygen saturation. So 15 may be too less. So you have to see that the patient not only adequately feel that they have enough hemoglobin for oxygen carrying capacity. The other important thing is that see, normally the blood pressure is maintained basically because of the systemic vascular resistance. And only 10% of the total peripheral resistance is contributed by the viscosity of the blood. Whereas in children who are cyanotic, they'll have the contribution by the viscosity of the blood to the total peripheral resistance is significantly more. Like instead of 10%, maybe 30%. So when you have a drop in hemoglobin from 18, say, to 15 grams per cent, they also end up in hypotension. Okay, so two important things to remember. Volume status, like Dr. Jyoti mentioned, has to be euvolemic always, neither overfilling because it will cause hemodilution, nor underfilling, which will increase thrombotic complications as well as produce inadequate cardiac output. Second important thing is you have to know what is the hemoglobin that is required. If it is 18, probably a 16 or something should be the borderline before you give a transfusion. Okay, so these things are important during the intraoperative period. Yeah, and if hypotension occurs during the intraoperative period, what is your vasopressor or inotrope of choice?
Then is the
Phenylephrine is
phenylephrine is the
Yes, you need a half-load vasopressor rather than an inotrope. You should not use a inotrope as much as possible. Carry on, Dr. Jyoti.
in this case, phenylephrine is the best because it doesn't it is an alpha agonist. It doesn't has an effect on the heart rate, and the SVR is maintained. And that's the reason we either give it as a boluses followed by a infusion if needed.
Okay. The other important thing I would like to add at this point is that you can use an inotrope if there is RV failure. That's a different thing. We are talking specifically now of tetralogy, which is uncorrected. Okay, go ahead.
Right, please. So what are the predictors for of fetal and maternal adverse outcomes in patients with a repaired TOF?
patients or the
Next
mothers
slide.
who are presenting with previous history of taking cardiac medications, those who have an IHA classification score of more than 2, the prolongation of QRS complex more than 180 milliseconds. It is also linked to sudden death, sudden cardiac death. Then prior history of cardiac arrhythmias, especially ventricular arrhythmias and atrial trachyarrhythmias, RV or LV dysfunction, severe RV volume overload, then moderate to regurgitation, tricuspid regurgitation.
Next slide.
Artery hypertension, significant aortic regurgitation, especially in unrepaired TOF. Then predictors of adverse fetal outcomes include adverse maternal outcome, presence of cyanosis in the mother, oxygen saturation of less than 85% of the mother, hemoglobin value of more than 20 gram percentage, and a hematocrit value of more than 65%. This will cause fetal IUGR, fetal intrauterine fetal death, etc.
Yeah.
So if the hematocrit is more than 60, they say that you go for a phlebotomy and come down on the hematocrit. Because the more the hematocrit, the chances of thromboembolism, embolic phenomena are more. And even it has a effect over the platelet function also. So that's the reason we usually we want a hematocrit less than 60 ideally for a better outcome. Next slide, please. If a repair has been done and the patient has significant RV right ventricular volume overload and pulmonary regurgitation, what is the plan of delivery?
In this case, as we have discussed, we'll be going for a cesarean section with choice of anesthesia being general anesthesia.
Okay, this is a subset of patients who are severely I'm talking specifically saying decompensated patients who have come as an emergency procedure, an emergency situation. I think GA can be done. But if your ventricular function, the most important thing is the RV volume overload can be there. But if your ventricular function is normal, we still go in for a vaginal delivery by giving analgesia and all. But if the RV is decompensated, RV failures, they're probably given an epidural may be dangerous in these patients. Then you go in for cesarean section and postoperative ventilation. Yeah.
And during general anesthesia, we'll avoid any kind of fundal pressure while extracting the baby because that can.
Yeah, that is one thing that we have to discuss. Singh. I'll put it like this: what is the general opinion regarding second stage of labor? Pros and cons. That's Nishana. Can you answer that? Otherwise, Jyoti can do it.
We can let the patient push with the adequate analgesia, but some of the reviewers are recommending active management of second stage of labor with forceps or decreasing the duration of second stage of labor. But in general,
Jyoti, can you explain it a little more better because postgraduate have to understand what it is.
Second stage of labor, they say that with proper analgesia and epidural analgesia, the patient can effectively push the baby out. But some studies have.
That means the uterine contractions by itself can push the baby out. That's what you mean, isn't it? Without having to strain.
Yeah, the straining efforts will be very less with proper analgesia. But in some studies, they say that you have.
And 1 minute. So the uterine contractions itself will bring the baby down. So do you assist that delivery?
Yeah, in some studies, they say that it for helping the patient for a prolonged second stage and all, we can try and give them a trial of vacuum delivery or a forceps delivery to ease the come down on the second stage of labor. And during cesarean sections, they say that avoiding of fundal pressure, because fundal pressure while extracting the baby might compress the inferior vena cava. Similarly, exteriorization of the uterus for suturing after the delivery of baby is also avoided to avoid a vagal response and even avoid a embolism, air embolism. So all these factors have to be considered while delivering the baby either vaginally or through cesarean section.
What is the criticism against this? That don't allow the patient to strain during second stage. What is the criticism against that?
The heart rate might go up. So that is and the stress of delivery. The SVR can go high. So that is the reason we have to actually balance between the systemic vascular resistance and the pulmonary vascular resistance. So a balance is really needed for such patients. So, and the heart rate has to be maintained. The rhythm has to be sinus. No arrhythmias should occur during the procedure. So that is the reason we always allow the patient to deliver with proper analgesia.
Okay, basically what it means is that if you allow the patient not to strain during the second stage of labor, the criticism against that is that it prolongs the second stage of labor, which is also harmful. Yeah. So you don't want that to happen.
Analgesia sometimes can prolong the second stage of labor. So to ease out the second stage of labor, we can assist the patient with a vacuum or a forceps delivery.
So there are pros and cons about second stage of labor, how to manage the second stage of labor. Very good. So carry on.
The next slide, please. Give me a detailed postoperative care of the patient with Tetralogy of Fallot.
Especially for patients belonging to category C and D, they require intensive care unit monitoring, minimum of up to duration of 48 hours. during the labor, and the physiological changes of pregnancy will maximize. Some of the changes in like cardiac output will be maximized during the delivery, and they will slowly decrease as the time passes and may last up to 6 months. The maximum complications are expected within immediate postpartum period. So during that period, the patient, these category C and D patients should be monitored in intensive care unit, their heart rate, BP, then should be monitored. There are increased chance of arrhythmias during this period that can be monitored. Strict intake output charting and monitoring should be done, because overloading the patient and dehydrating the patient can have its own disadvantages. So the volume status of the patient should be monitored, and adequate analgesia during the postoperative period postpartum period should also be into a consideration. Then these patients, this is the ideal time for counseling the patients regarding if the patient is an uncorrected or palliated patient. We can counsel and make the patient go for a corrective surgery, then go for next pregnancy and future for pregnancy planning can be done during this period.
We can also give stress on contraception after delivery, and explain her in detail about the risk of future pregnancies. So counseling of the patient is very important post-delivery.
So will you ventilate these patients?
These patients who are coming with right ventricular failure, who has undergone the procedure with general anesthesia, some of them may require postoperative ventilation.
What about DVT prophylaxis?
DVT prophylaxis should be initiated with low molecular weight heparin, because this is a period of prothrombotic state.
What are the choices now? What form is it going to be? A pharmacoprophylaxis or pharmaco plus mechanical prophylaxis?
Mechanical as well as pharmacological prophylaxis with stockings, or a DVT pump, the deep venous thrombosis pump can be
Probably
used.
the first day we'll have to go by mechanical prophylaxis, because surgeons won't allow. There's always an increased risk of bleeding happening in these patients. And after the first 24 hours, probably we can go ahead with the pharmacoprophylaxis, isn't it? Probably that will be better. Yeah. Jyoti?
Yeah. So it's similarly in patients who have undergone a shunt surgery, the axis of arterial on the same arm won't be, it will be difficult, because there will be flow related issues, and so arterial line in the opposite limb is always planned, and there might be a compromise in the pressure monitoring if you put an arterial line in the ipsilateral limb.
Yeah. Jyoti, can you summarize the whole thing?
So the next slide, please. The patient with Tetralogy of Fallot has good survival after repair, and patients with a corrected TOF and a good ventricular function can tolerate pregnancy well. With patients with ventricular dysfunction, significant valvular diseases have a very high risk of development of arrhythmias, ventricular failure, and hemorrhage. And to summarize, one thing we have left during the delivery, we can use oxytocin, but recommendations are more towards methyl ergometrin, which is a drug of choice for prevention for uterine tonicity. Both can be given, but studies have said that methadone is far better than oxytocin.
Methadone is far better than oxytocin. Okay, fine. Okay. What about carboprosine and all those things? All those drugs, group of drugs?
Be used, but the methylergotamine, this has the lowest cardiovascular effects, so it can be given at a dose of 0.1 to 0.3 mg IM instead of giving oxytocin.
What about the incidence of postpartum hemorrhage? Because they say that it can be high, isn't it? What are the reasons for that?
Postpartum hemorrhage is very high in patients with congenital heart disease in general. This is because they have a very the pregnancy causes this is due to atony of the placenta. In those patients, in patients with congenital heart disease, especially those patients with hypoxia, there is changes in the vascular endothelium. There is a defect in the vascular endothelium, which is causing the increased chances of bleeding and atony.
Okay. So some people say it is probably because of the people are afraid to give oxytocin also. It causes some decrease in systemic vascular resistance. So inadequate dose of oxytocin. That's why Dr. Jyoti said probably other drugs, methogen can be better drug of use. Dr. Ridhima, we have just come to the end of our discussion. Shall we
Yes,
take
sir.
the questions or you would like to intervene now?
Yes, sir. I must congratulate Nishana for it needs lot of preparation and courage to present nationally, and definitely the credit goes to our moderator of the session, Dr. Suresh sir and Dr. Jyoti ma'am. I think thank you for sharing your time experiences with us, and you have really made this class very simple and informative, and each and every one of us benefited. So, can we take few questions in the chat box?
Yes, you will take up the questions and we'll answer it if you want.
Okay, sir.
Yeah.
So there is a question like, is there any role of diuretics and its use or intravolume vascular depletion like that?
Yeah.
Role of diuretics in this patient?
Jyoti?
So,
Jyoti, would
during pregnancy with TOF are used with caution because the volume status is a most important factor in patients in these patients with TOF. So we use diuretics with caution, but in the postnatal period, they say that we can use spironolactone for breastfeeding mothers to help out to come down on the volume overload. But during pregnancy, during delivery, diuretics are used with caution.
Yeah, just add on to that. See, remember that the use of diuretics is strictly used in patients who have got RV failure. It's not for any other category of patients. And when we use diuretics, you have to be extremely careful because when you remove too much fluid from these patients, the viscosity increases and that can lead to another complication, which is thrombotic complication. So you have to be extremely careful and it has to be controlled by the cardiologist who's with you, because the entire picture that what we have discussed is a teamwork between the gynecologist, the cardiologist, as well as the anesthesiologist. So we have to involve them, and they should know when to stop diuretics, what to give, and how much to give. I hope I've answered your question.
yes, sir. So next question is like, should we reduce the dose of fentanyl, or should we give it like ideally that we give in the normal patients?
To begin with, we can give 100 mics of fentanyl initially, and after delivery, we can give delivery of the baby. We can give more for analgesic purpose.
Yeah, I also agree with what Jyoti said. We'll give about 100. See, remember two things. One is if you give too much of fentanyl can easily cross into the, I think it can cross into the blood, into the fetus and can cause respiratory depression in the child. So when you do that, you have to be alert the thing. But if you don't use fentanyl and use some other drugs, it will produce adverse cardiovascular effects. So that's why we have to use small amounts of these drugs also. That is the answer to that question.
Laryngoscopy and intubation has
Yes.
to, and we all do cases, such high risk cases, under monitoring of, we use BIS to, the awareness of the mother is also very important. So a combination of fentanyl, ketamine and thio is very well needed to give anesthesia for such mothers.
And I think most of the institutes now have a QNOX for the nociception or analgesia. We can monitor with that also.
Yes.
That can help us for needing the pain or anything. So,
Yeah.
is there any role of Milrinone, sir?
I think I'll take that question because remember one thing, if you have an uncorrected tetralogy of Fallot, remember that the obstruction of the right ventricular outflow tract is fixed. It is not going to change. Now, when you use Milrinone, what happens? It reduces the SVR as well as the PVR. But SVR, decrease in the SVR becomes significant. So what will happen? If you use Milrinone in this patient, it is going to divert all the blood from the RV or from the systemic circulation into the pulmonary and into the, from the unoxygenated blood into the systemic circulation and worsen the oxygenation occurring in these patients. Changes in pulmonary vascular resistance does not affect in a case of uncorrected TOF. On the other hand, if you have a patient who's got who has been corrected and he's got RV dysfunction, yes, Milrinone may have a role because it also reduces the pulmonary vascular resistance as well as the systemic vascular resistance. In these situations, the additional advantage of using Milrinone is that the RV compliance can, especially if it is hypertrophied, it will improve. So in a corrected tetralogy of Fallot, yes, Milrinone may have a role. In an uncorrected tetralogy of Fallot, there is no role for Milrinone.
Okay. So somebody has asked, can we use for a graded epidural? And one more question is like that, use of segmental epidural. I don't know what they mean to say, but they want to ask this, is it safe for this patient for segmental epidural or graded epidural?
In such cases, always we give a graded epidural only because if you give a bolus of epidural drug, that is whatever, Linsocane, Ropivacaine, it might create a very drastic fall in the SVR. So we don't want that. So we always use the epidural drug that is either Sensocaine or Ropivacaine. We use in a graded manner that you give 5 ml. We wait for the level of anesthesia and then we give 5 ml. That is the way we give it. Even in a combination of combined spinal epidural, the drug which is given is a very low dose of hyperbaric bupivacaine, which we give as 3 to 5 milligram of bupivacaine is used for spinal, and rest of the drug is given through the epidural. So we create a segmental approach to such kind of patients. So we don't give it as a immediate bolus, like a full bolus to as in normal patients.
So it is a graded epidural always, right?
Yeah, sir. Actually, graded epidural is an established technique for these type of surgeries for a long, long time. And segmental spinal is evolving, and segmental epidural in this type of surgery has not been established. So we are talking about the safety of the patient. It's better to go to the established techniques here, especially in our setups where we hardly have any referral centers nearby. So I think we should go by the established technique, the safest for these type of patients.
Yes, yes.
Because we are dealing with two lives now at the same time.
Yes.
So they have asked you, what if the patient come for emergency LSCS? What is the choice of anesthesia? Like, should we go for regional or GA?
Jyoti?
The emergency situation is if it is a fetal distress where you don't have time for a regional technique. In such scenarios, we always go for a general anesthesia. And the second aspect is the mother. When the mother is severely decompensated or she has a severe RV dysfunction, she is in failure, we always go for general anesthesia. We don't try any kind of regional techniques in such patients.
Jyoti ma'am, shall I ask one question from
Yes,
the
sir.
behalf of our peripheral anesthesiologist? Suppose this type of unbooked patients lands up at around 2 a.m. in the morning on the table with the fetal distress and all type of a bleeding and emergency scenario where obstetrician has to perform a section. And the anesthesiologist just came with a rubbing of his eyes and seeing the patient. How will he come to know at the presenting symptoms? Because these will be masked by the physiological parameters of the patient at that time, plus the uncorrected tetralogy of Fallot, how the presenting symptomatology should alert him at that very time.
Raju sir, I'll run away.
Then
No,
the
sir, it's very important actually. See,
Yes,
unbooked cases presenting at night, and that to an anesthesiologist who says my life is going to like, and the referral center nearby is more than 60 kilometers far
exactly.
away. So how do we manage such? This is a very important scenario, sir, in our settings. That's why.
Jyoti?
So in such scenarios, we can go do a detailed examination, a quick detailed examination. Let us check the saturation, room air saturation, or auscultation. We can find a systolic murmur, a pansystolic murmur, and how in a short, quick history about any hospital admissions in the past, or issue on any drugs, which is likely to affect our choice of anesthesia. And it depends on the scenario, how distressed the patient is, the mother or the baby. Depending on that, we can give, if it is we have time for a short quick spinal technique. There are studies where people have tried microcatheters into the spinal dura, and they have given drug in a graded way. So we can try that if it is a real emergency. Or else, if it is not, where we have time, we can do a graded epidural. If
Ma'am, actually,
Raju sir,
problem here is, suppose I'm attending, just putting myself in the shoes of a peripheral anesthesiologist, the patient presenting to me with the fetal distress, the obstetrician is just shouting that the voice, ki, let's go, otherwise we will be getting this patient off. Then, even if hear a systolic murmur or pansystolic murmur or auscultation, I may not be able to diagnose the tetralogy of Fallot at that particular time because pansystolic murmur occurs in so many conditions. And the management of different conditions having pansystolic murmurs sometimes contradict each other. So these are the problems. We don't have echo in the peripheries. We don't have any, even ECG machine is very difficult to get there. So those type of things are really going to have a challenge for us. And when we refer these patients to the periphery, from the periphery to the higher centers, I think 60 kilometers at a night time, the communication as well the logistics are very difficult to arrange. That's where our challenges come. And I hope from Aster Medicity, if I get a direct bus or a direct flight, it will be easy for me to send to you. But that's a real scenario. Here, I think we should have some protocols, guidelines from our peripheral anesthesiologist to referral or to manage such patients. I think Dr. Suresh sir is the right person to be part of that core committee where we can have the policies and protocols making for these type of scenarios. Because we can do a very good research work in the centers. We have got all the facilities, we have got good teams, but ideally, till our peripheral setups are not equipped or not made properly aware, we will not be able to progress in the field of cardiac anesthesia or any such specialist anesthesia till our whole anesthesiologist fraternity is involved. So these type of scenarios are difficult
I
for us.
fully agree with you, sir. Even in Kerala, where most of the hospitals are big, they don't take up such patients. But one thing I can easily tell you, if you can take 5 minutes to sit with the obstetrician and tell the relative, see, I am seeing a patient who is cyanotic. Probably she has got a cyanotic heart disease, and things may not go in the right direction if I give anesthesia for this patient. But if I have to save the mother more important than the child, if these words are clearly imparted to the patient's relative, we call it the multidisciplinary team meeting with the relatives, the near kin and kith of the patient, you can save your skin.
Yeah.
Okay. The second important thing is if you see cyanosis and hear a murmur, you have to be extremely careful. Now, what do you do in a peripheral setup like the example that you gave? Patient, your referral center 60 kilometers away. Probably intubating that patient with the least stress and get the baby out and then transferring the patient to the referral center may be the best option that you have.
Yeah. Agree.
Agreed. So the crux is sitting with the relatives and telling them you have a problem on your hands. I think that is the most important thing.
Yeah, that's what the teaching has also been there right from the postgraduate curriculum. If you get these patients, give GA, intubate the patient and save their life for the time being till you get a help from the higher centers.
Yes.
That's the only teaching item we also got during our PG days, sir. The
And-
scenario is still same in the peripheries, not in the centers. I agree with you, sir.
After delivering the baby, the management of the mother will be far more simpler than managing.
Yeah, easier. Not simpler, but easier than the. Not simpler, ma'am. It's easier. Yeah.
Yeah,
Next
Rishi.
question.
I think Dr. Samapta is looking continuous spinal anesthesia is better, I think, ma'am. And to evaluate, we have to see pulmonary edema and right ventricle failure. That is their process of thinking, ma'am. You're saying is continuous spinal is better or not?
Continuous spinal, continuous we won't, because continuous spinal will have more effect over the SVR, that's systemic vascular resistance. There will be a lot of hypotension occurring, and we don't want that. So to maintain a proper balance between the systemic vascular resistance and a pulmonary vascular resistance, it is always that is a important goal in giving anesthesia for a pregnant lady with TOF. We don't actually advocate using a continuous spinal anesthesia.
I think one of the important messages that we have to transmit to the postgraduates is don't do anything that is you are not familiar with. That's very, very important. Do what is established, especially in the early years of your life. So if you're not familiar with continuous spinal anesthesia, don't try it out. It may have its own consequences. Like Jyoti said, you may give a segmental spinal anesthesia, which may be, you said microcatheter and all. You can give that. But even if I'm not familiar with any of these things, so I will not do it. I'll try what I am familiar with. That should be the attitude, rather than do anything unusual and get into trouble.
Always a
I
graded
think
or general anesthesia. That is the best choice in such patients.
Ma'am, that is the message I think we should give through this class, because these type of established techniques, we are working for the safety of the patient. We are not here for at least advanced research and bringing something adventurous into the field.
Yes.
More for the safety of the patient and a teaching curriculum that PG should adopt these practices before they go into even to the peripheral practice or some other institutions. The message is clear.
Ridhima?
yes, I think very well explained, sir. Whatever technique you are conventional or your institute is familiar, one should use that. You should not experiment in all this patient. Another question is that preloading is better or afterloading is better in this patient?
Jyoti?
Ideally, in such patients, in cesarean patients, with usually under GA, if we should not preload. Actually, we should give fluids along with the anesthesia. There's no such a thing like preloading, but in the volume status has to be maintained. That is the dictum in such patients. We should
Co-loading, you call it, no?
not
Co-loading.
co-loading will be the better word for it. We have to do a co-loading in such patients because the volume status has to be maintained, and you should not give too much of fluid so that the lungs get flooded with fluid, because it's a thin line between giving too much of fluids and rather putting the patient under danger. So it's the volume status has to be maintained so that the patient doesn't go in for thromboembolism in the future. And the blood, we have to take care that during surgery, the bleeding has to be properly assessed, and according to the bleeding, we have to give fluid as well as blood and blood products.
Next question.
Ma'am, there is a difference. We have any difference between the time of delivery, after delivery? What should be the approach of fluid administration before delivery of the baby? Because, after delivery, the contraction of the uterus, the blood coming into circulation, and suddenly changing the hemodynamics, the internal compliance of the vessels also because of the hormonal changes. So I think, is there any difference in the approach of the fluid resuscitation?
Delivery, The water transfusion is more. So the lot of volume might go into the central blood volume. So that judicious use of fluids should be there, because the patient can go in for a pulmonary edema. Lot of almost, they say that almost more than 50 to 80% of the blood volume is being transferred into the central compartment after delivery of the placenta. So you have to be really careful when you give fluids during this time.
So I personally feel one of the important things that we are missing out here is that what is the mean arterial pressure? Because mean arterial pressure has to be maintained around 60 to 65 millimeters of mercury. It falls means probably that it also indicates the systemic vascular resistance is low, and most of the volume is going into the systemic circulation, bypassing the lung. So maintaining an adequate mean arterial pressure may be very important in these patients. There is no textbook or literature which tells you what exactly, how much fluid you have to give, how much you don't have to give. A lot of people have to balance both the systemic vascular resistance as well as the hematocrit, as well as the volume that you give to these patients. I would put it like that.
So that means, sir, if we are managing, suppose we have to manage these cases in the setup with the minimal resources, because putting an arterial line there is a very difficult. We may not having the transducers and the monitors for the arterial line in the peripheries or even in the smaller hospitals of big town. And putting a CVP line is also not going to be helpful with the variation, with the pulse variation, with the respiratory variation, with the PEEP and everything, or the ventilation. So I think at that time, it will be difficult to monitor the mean arterial pressure from beat to beat variation in such cases. So what is the alternative for that if we don't have our arterial line in those cases, sir?
So you don't have to put an arterial line. We can just go by every 3 minutes. You can monitor. You have an automatic BP monitor.
That we can, sir. We can calculate, but sir, those monitors can always give a erroneous reading of 5 to 10%, sometimes 15% also. But then, having a 65 and having 55 is altogether a different BP.
Yeah, what I think is anything more than 55 should be acceptable, but less than 55 can be dangerous. Mean arterial pressure, I would put it that way. So it's not necessary that all of us should be putting arterial line and a central venous line. Those facilities are available, well and good. Otherwise, you should be using whatever is available. Try to maintain the mean arterial pressure. Of course, it may be a disadvantage when you have the ordinary blood pressure monitors. But then today, if you have a monitor, automatically non-invasive blood pressure will come. So that will give you the mean arterial pressure also. We'll go by that.
Yeah, those are the great messages, because coming from the mouth of a cardiac anesthesiologist for managing such patient, these are really taken as a message to be carried forwarded. These are required actually. That's advantage of having these classes and these type of messages. I think, Ridhima, this is a clear cut now. Dr. Jyoti and Dr.
Yes,
Suresh Nair sir has given a very good reply to this query.
exactly. Sir, there is a lot of confusion about inotropes and vasopressors. They are very, asking whether we can avoid phenylephrine as it can cause bradycardia, or NORADR is the agent of choice. So many of the postgraduates are asking this.
Okay, I'll take that question, because we need to differentiate between inotropes and vasopressors. Inotropes are drugs which increase the contractility, it increases the heart rate. Now, when you give it in a patient who has got Tetralogy of Fallot, it produces an increase in the heart rate, which means oxygen demand is increased. And many of these inotropes also have got decrease in the systemic vascular resistance, which means more blood will go in an unrepaired tetralogy, will go into the systemic circulation, which means more desaturation, which is disadvantageous to the patient. So in these patients, unrepaired Tetralogy of Fallot, if you have an hypotension, like the previous question that Dr. Baj asked, your mean arterial pressure is low, I would use a vasopressor like phenylephrine or noradrenaline. Now, the question whether this will cause bradycardia is a very good question. They produce a reflex bradycardia. That means your mean arterial pressure shoots up to 200, then it will produce a reflex bradycardia. Otherwise, it will not produce a bradycardia. Phenylephrine, for example, does not have any effect on the heart. It's a pure vasoconstrictor. That's why Dr. Jyoti said we will prefer to use phenylephrine, because it does not have any effect on the heart rate. If it produces a bradycardia, because your mean arterial pressure is actually shorter. Noradrenaline, again, if it produces a very high blood pressure, it can produce a reflex bradycardia in these patients. So these drugs are the drugs of choice in a patient with unrepaired tetralogy of Fallot. Now, the scenario becomes different when a patient has got a repaired tetralogy with RV dysfunction. In these situations, we are looking at a situation where the RV is failing. Okay, because of pulmonary regurgitation. In those patients, you need something to increase the RV contractility. Those situations, you need a drug which will increase the myocardial contractility as well as reduce the pulmonary vascular resistance, so more blood goes into the pulmonary circulation. Here, you can use very small dose of adrenaline because it has no effect on the pulmonary circulation. You can use drugs like dobutamine. Okay, dobutamine can be used. It increases the myocardial contractility, reduce the pulmonary vascular resistance as well as the systemic vascular resistance. This is a situation where you can use milrinone if you want, because it reduces the pulmonary vascular resistance. So in these situations, ionodilators, we put it more carefully. They are called ionodilators. That is, increase the myocardial contractility as well as dilates the periphery. These drugs can be used when you have RV failure or LV failure. Whereas in an unrepaired tetralogy of Fallot, if the BP drops, vasopressors like phenylephrine or noradrenaline or vasopressin may be the drugs of choice. I hope I am clear with that.
Yes, sir. So coming to the uterotonic, they are saying is oxytocin is better or methyl ergometrin is better? And is there any contraindication for the carbopros to be given?
Jyoti.
Both can be given, oxytocin and methergine, both can be given. But studies have shown that methergine is better over oxytocin. And they also have said that we can use carbopros or other analogs of prostaglandin analogs to control the bleeding. It can be used as a uterotonic. Prostaglandins can be used as a uterotonic. But the first choice will always be methergine. We can also use oxytocin.
So, what is like common arrhythmias in these patients, and can we use a myodron and rule of defibrillation?
Common arrhythmias are more of ventricular as well as atrial tachyarrhythmias, and we can use antiarrhythmic drugs, and cardioversion is also being tried to control the arrhythmia.
Yeah, I agree with Dr. Jyoti. See, you can put it this way. If these patients come with at 6 months of pregnancy with arrhythmias, that's an ideal time to start beta blockers for these patients. That would be an ideal good drug to use in these patients. Now, if you see them later on, you may use cardioversion. Remember one thing, cardioversion does not affect the baby. So you can give cardioversion for these people in normal way that you use for any other person. So baby is not going to be affected by cardioversion. So you can use cardioversion, no problem. So defibrillation is possible just like any other patient. What was the first part of the question? I just forgot.
A myodron, sir, can we use a myodron and common arrhythmias?
Amiodarone can be used, but I think I've read some articles which says that it can slow down the fetal heart rate also. I'm not sure whether it actually crosses the placental barrier, but it may cause a reduction in the heart rate, which we have to inform the neonatologist early itself.
So they have asked that usually these patients have higher hematocrit. So is there any cutoff for the transfusion of blood for the blood transfusion?
I think I answered that question earlier. Like if the patient may have 90 hemoglobin and then post-operatively it comes down to 16. Now what happens is that the oxygen carrying capacity for that particular patient was actually sufficient only with 19. So when you bring it to now to 16, it may cause a decrease in the tissue oxygen supply. The second important thing, like I said, is the viscosity of blood. The total peripheral resistance in a normal person, the viscosity of the blood contributes only 10%. The remaining 90% is by the arteriolar tone. Whereas in a patient with tetralogy of Fallot, the viscosity contributes almost as much as 20 to 30%. which means that if you reduce the hemoglobin from 19 to 16, he may develop hypotension, and you have to build up the viscosity of the blood. So these two reasons, you have to look at it. Now, how do you identify whether 16 is adequate for the patient or not? Now, you have to look at certain things like blood lactate level. Sometimes you look at the mixed venous SVC saturation. All these are imperfect. They're not exactly right. There is no single way of looking at it because of the congenital anomaly that is existing in these patients. But in a patient who has repaired tetralogy of Fallot, you can look at the SVC saturation. If it is less than 70%, it means your saturation is inadequate in a person without RV failure. So it's a little complex situation, and then you have to decide whether if a cardiac anesthetist is there, that is the best situation. If you're in the periphery, like you say, you try not to reduce the hemoglobin, say from 19, bring it down to 70, but don't allow the hemoglobin to come down to 12. You try to maintain above 16 grams per cent. That will be the safe thing to do in a peripheral setup if you're doing this case.
So the next question is, sir, if the patient is having preeclampsia also and corrected TOF, how we are going to proceed for this? I
Jyoti?
think corrected TOF with the preeclampsia coming for a cesarean section or a delivery.
If it is a milder version of preeclampsia, like a mild to moderate preeclampsia, we can try delivery with labor analgesia, giving a proper labor analgesia, and deliver her vaginally. And if she is in a severe preeclampsia with TOF, then general anesthesia will be the better choice, because
I think that blood pressure management becomes important in that.
better controlled management of blood pressure, the hemodynamics will be better with general anesthesia if she is in a severe preeclamptic state.
So the click is not to reduce the BP so much and not to get the higher one. So I think clinically you have to manage like that. So next is that, ma'am, if how common is to come across, Dr. Panna Thakkar wants to ask, how common is to come across a case of uncorrected TOF in a rural area? Suppose a patient come across in a rural area, how we are going to manage it? I think we have already discussed that sir has told ki you intubate it and you try to deliver the fetus if it is an emergency, try to save and transfer it to that tertiary care center. Anything else you want to add, ma'am?
I think the southern states, like as well as states like Gujarat, which have excellent school programs, you won't see any tetralogy coming uncorrected in adult patient, because these states have got excellent program going on. But you still can see in probably in northern part of India. I'm not differentiating. Please don't mistake me. But you can come across rural areas with tetralogy which is uncorrected. Remember, these patients are those who have either one, they have the more favorable tetralogy of Fallot, like the pulmonary stenosis is not very significant. Then only they can survive to adulthood and get pregnant.
True, sir,
Or they may be pulmonary atresia with a lot of MAPCAs occurring in these patients. That picture is totally different because they may have pulmonary hypertension, which you have to tackle. Now, if you come across a patient with tetralogy in a rural setup, please send them to a higher center. If you get them in an emergency, the answer is what I've already told you. In an emergency situation, intubate.
I think in any situation, we should always consult a higher center, and with the telecommunication after COVID, we have learned we can always have expert opinion. I think it is always good to address your limitations and do the needful for the patient. So Madhuri ma'am want to ask, suppose the patient with the uncorrected TOF taken for LSCS develops a TET spell, how to diagnose? I think there will be sudden cyanosis and desaturation rather than. Ma'am's question is how to diagnose like if you're taken for a LSCS.
see, the only thing that you can do is that you know that the patient is cyanotic. We don't know what is the diagnosis unless you know how to do an echocardiograph and make a diagnosis yourself. So what do you do if it is see, there is a very little that you can actually do. But remember one thing: these patients with uncorrected tetralogy are used to low saturation, so you don't panic. If you can achieve the same saturation when you first saw the patient, that's it. Transfer the patient to another bigger center. That's the only thing you can do. You can't do anything more than that. You can't do any intervention there to save the patient's life. Don't try to keep the systemic vascular resistance a little high and see whether the saturation is actually improving. Second thing, try to maintain the patient's hemoglobin on a higher level. See if that is improving the saturation. All these things, simple things you can do and transfer as early as possible. And the most important thing I keep repeating is that before you touch the patient, have an MDT, multidisciplinary team with the patient's relative, impart to them the significance or the dire consequences of giving anesthesia or what the patient is actually facing. That is the most important thing nowadays.
I think, sir, if we have already diagnosed...
Just wait, Ridhima, just wait. I'm telling you, sir is very much right here. The most important part is the documentation and the consent. And if it's video recorded, it is best to save skin in any state of India. Maybe the southern state, the Kerala, is the best state to provide the healthcare infrastructure. But it is always better to have a documentation and video consent in these type of cases. Moreover, if you ask me, the video, this conferencing at the night, who will wake up at 2 o'clock? Nobody, no center in India will take your call. It is just I'm telling you, eye wash. You can have these type of things in elective state of matters. No anesthesiologist at the night will take up your call and in a video conferencing will be telling you do this, do that. It is you, the person who's attending to the patient. He has to use his clinical skills, his equipment, whatever possible resources with him, the manpower with him to save the life, to take the patient to the higher center. Because sometimes I think it may be required the person has to go. The anesthesiologist himself has to accompany the patient. You can't leave these things on the technician to transfer the patient. You want to save a life, this is the best way to do the things. But I disagree. No, even whatever the technology is advanced, nobody is going to help you in the night at 2 o'clock. Nobody picks up a phone. Forget about the taking help from anybody. It's the attending anesthesiologist. And I think you better take along with you the obstetrician or the surgeon, whosoever their team. It should be a teamwork. That I think
So
best.
one more
the
point I want to tell you. Video recording is, all of us have mobile phones where you can easily video record the conversation.
That is the
between
best
the anesthetist, gynecologist, and the patient.
Yeah.
Yes.
And as far as TET spell is concerned, if we have diagnosis, then can we do that D-chest, morphine and phenylephrine and try to maintain the saturation as the patient was having
patient.
previously?
In a pregnant patient,
cesarean.
No,
sir, for a cesarean, I'm asking what we can do to increase the SVR or something in a rural area when we really don't have anything. We have a life-threatening spell, TET spell.
No, madam.
I think
see, let me answer that. TET spells will not happen after 2 years of age. Because by the time that TET spell, one of the theories that they say is infundibulous spasm, that will become fibrosed. After that, it's a fixed obstruction. Nothing will happen to this thing. In such situation, and second thing is, like sir said, in a pregnant patient, it's very difficult to give a knee chest position or anything like that. So the only thing you can do in such situations is give a continuous infusion of norepinephrine or vasopressin. Something will increase that SVR and get the baby out as early as possible, or transfer to another center, whatever is possible. You are in a very bad shape.
I think Madhuri ma'am question is answered, and ma'am is also raising the hand. Ma'am, do you want to have say something?
Yeah, that's what sir has already told, na, that it's very rare situation. But I have read a case report where they had such a situation, and then they have given beta blocker, that is esmolol, to reduce the infundibular spasm, which can lead to the TET spell. Of course, and 100% oxygen.
Madam, I
but
generally
it's very rare.
really don't think that will
very
work.
rare, of course. Yeah.
Sorry. Because this infundibulous spasm usually occurs at the age of starting from 3 months to around 2
Not
years.
in an adult. Okay.
Not in an adult.
Okay.
But if your patient is having tachycardia, beta blockers per se may help. That's all.
Okay.
But sir, it will add to the spasm beta blocker in the compromised
Bronchos.
lungs also.
Yes.
That's another, it's a double-edged sword.
Yes.
So, sir, PGs want to ask, can we use etomitate as an induction agent?
Jyoti. Etomitate.
It can be used because it has at least a myocardial depressant action. I have hardly done any cases of pregnancy with TOF, so sir will be a better person to answer this question. But as far as hemodynamics is concerned, etomitate has a least cardiodepressant action, so it can be used. Ale.
Yeah, I agree with Dr. Jyoti, but I have not been very much impressed with the etomitate. I would prefer to use ketamine as an alternative rather than etomitate. There's nothing against etomitate. You can use it if you want, but we are more used to ketamine, so ketamine would be a good choice in these patients.
I'm very happy
Okay,
to
sir.
listen to these type of things, sir. Sometimes some people, even if a person of your caliber, your stature of a cardiac anesthesiology, having the same views which I am having, I think I am feeling good about it.
Okay.
I think low saturation means how much low should be allowed?
This is again a very debatable point. Like I said, I would rather go by the hemoglobin and remember, if you go by saturation, remember one thing. When your SpO2 drops below 60, you are in nowhere because it is unreliable. When you go below 60, you can't say what is the actual saturation. Pulse oximeters won't reliably tell all these things. So if you're, like I said, when the patient comes in, I would like to see what is the saturation of the patient. If suppose it is 80%, I would try to maintain it 75 to 80, not bring it below 70%. That should be my policy if you're working in a peripheral setup. And important thing to remember is that your 70% is not going to kill the patient because these patients are used to low saturations for years, 20 years of their life or 25 years of their life. So they will tolerate the low saturations. But don't allow it to fall precipitously like less than 50%. That will be dangerous. And try to keep your mean arterial pressure more than 55 millimeters of mercury at least.
I think, sir, whatever saturation patient has come, we should maintain it. I could maintain as long as. Sir, is there any different recommendation for PPH if during LSCS in uncorrected TOF? Is the management is different in these patients if the patient is uncorrected TOF?
Jyoti, can you
I
answer?
think Dr. Jyoti answered this question a few moments back, I think.
So we can use all kind of measures to control postpartum hemorrhage with uterotonics, as well as we can use Bakri balloon, which is another method which is used by gynecologists to give a tamponade, uterine tamponade to come down on it will increase the tone of the uterus as well as prevent postpartum hemorrhage in a very drastic way. These are the measures we usually use as a.
So I think symptomatic treatment.
Jyoti,
yes, sir.
There is a practice of using intrauterine vasopressin.
No, that is not used in such patients because vasopressin will create more harm to the patient, especially with a cardiac disease. So in such patients, we don't use vasopressin.
I think that's a very important message that she's saying, that do not use intramyometrial vasopressin. It can cause precipitous rise in mean arterial pressure and cause reflex bradycardia in these patients. So I think that's not a good idea at all.
And more important, sir, more important to stop the obstetrician to use that.
Yeah, I was also saying. obstetrician, they have a lot of urge to use vasopressin these days. In our center, they are right now they are using it vasopressin so frequently. Is there any role of frequent ABGs or anything like that in these patients, or should we do clinical assessment?
Yes, but acid-base balance has got definitely a role. One of the things that I would look is what is the baseline venous saturation of this patient, SVC saturation of that patient is very, very important. Second thing is the severity of the acid-base test, because if you see normal pregnancy, they will have a normal pH with a low PCO2 and a slightly in the acidotic side. These things will worsen in a tetralogy patient. So knowing what is the baseline, what is the baseline bicarbonate in this patient, what is the baseline is PCO2 in this level patients are very, very important, because when you see the change in pH, you know whether the patient is acidotic, whether the PCO2, if it is high, where is bad, good, bad. Yes. So serial base acid base status as well as baseline acid base status of the patient should be known as early as possible.
And factors which, these are the factors which will rise the pulmonary vascular resistance, acidosis, the hypoxia, the hypothermia. So all these factors have to be taken care. So see, ABGs are, they will give you a proper explanation to all these. We can get a proper information through the blood gases.
Yes, I think if you have an institution has that provision, we should use intra-arterial line and CVP line for the better monitoring. And as we said, discuss if we are in a periphery, we should do best for two baby and the mother and try to shift the patient as soon as possible.
In fact, what I would suggest is that even when we are planning for epidural analgesia, many of these patients may land up in cesarean section. So what I would suggest is that having an RT line would be useful, because you will know when the patient is deteriorating, and when you should ask the obstetrician whether to take a call on cesarean section. So if we have the facilities, having an RT line would be definitely useful in these patients.
And I think it should be put in early rather than when we are missing the pulse or it is getting feeble. Early introduction of the arterial line and all this are better.
Yes. Yes.
I think, sir, we have taken all the question. Dr. Somappa wants to have ask a question. Sir, can we
Yeah, please.
unmute them? Somappa. So,
Okay, sir.
see, there are some SQNSTR Somappa Ratan.
I think everybody can unmute themselves. There is no problem.
Anyone if want to ask question, please. All of us are there.
3-4 minutes only.
3-4 minutes only. I think all the questions have been answered, sir, very well in the chat box. So there's no question now. So meanwhile, can we present our certificates for the...
Yeah. I think no question anymore, because I think whatever has been told today, I never had attended such a good class of Tetralogy of Fallot, and with the pregnancy and emergency cesarean section. It was an eye-opener. Also, many facts, I think, which were not known to me also, I think very important. If that, at this age, if I am knowing certain facts, so that means there will be people who must have today imbibed many good points from this class, and they must have got richer. These type of classes will be available on YouTube also. Tomorrow, if you have got any problem, you can go and watch this class. You can see the queries being answered by Dr. Suresh Nair and Dr. Jyoti Madam, and you can take your patient in that way. I think that's the best way, rather than going calling at night 2 o'clock the other anesthesiologists. You can still watch on the YouTube at what was the remedy for these type of things. So I think that's much easier. So anyway, but this is a good class, and I really loved every part of the class, every discussion. Now I think we should be felicitating our all our moderators and presenters. Our PG student has done very well. So is my screen visible to everyone?
Yes.
So Suresh sir,
Yes,
I'm really indebted to you for your precious time, your guidance in preparing your PG student, as well as moderating the class in such a manner that every query has been answered. And most importantly, nothing adventurous you told. That was a very basic things for everyone to practice as a postgraduate student and a practitioner. So, sir,
Thank
we
you.
are really thankful to you, and this is our small token of respect for you. This is a certificate. It will be mailed to every moderator and presenter.
Thank you, sir.
Jyoti Lakshmi ma'am, this is for you also. We feeling very happy and indebted to you for this class. You really answered everything very well, and you took care of your PG student also. You sitting by side of her makes sure that she is also feeling more confident. Thank you, ma'am.
Thank you, sir.
Then
Dr. Nishana.
Dr. Nishana Sharin, full name. You did a good job. I think you have prepared yourself for the examination under the guidance of Dr. Suresh and Dr. Jyoti. You will be doing good in the examination also. So you presented very well. I think your madam sitting by your side was a calming, soothing experience for you to answer all these queries. Good. Keep it up. And Madam Dr. Ridhima Sharma, thank you for moderating the class and taking out so much of energy to ask these things, all the questions. And Bidisha, you made a debut today. So this is
Thank you,
a
sir.
token of respect to you also. So that's from the presentation of our certificates. And more importantly, I like to thank Dr. Madhuri Kurdi and Dr. Nishant. They have always been my backbone in holding these classes, and all the small things, they do it in a very meticulous way. So thanks to both of you. And thanks to all the delegates, the teachers, the students who have been attending these classes. I think you must have got richer today. And these are just like कहते हैं ना बूंद बूंद से सागर बनता है. With our all PG classes, I think everybody will get richer by the day. Every passing year, you getting all these classes on the YouTube, and you can watch them again and again. Sometimes these classes may be much better than the real classroom teaching, because these are answered by one of the most experts and most well-read people. So I think that's the best way. We are having a knowledge of entire India. Entire India is becoming a very small village now on the ISA YouTube channel. So that's all from my side. And I'm really thankful to everyone, to all the people attending here. Since it's time now to say goodbye. So I always say, to end these classes, before the end this class, we always say, long live ISA.
Long live
Long
ISA.
live ISA.